Head Injury Care. This is going to be presented by Suhas Bajgur, who is affiliated with the University of Texas School of Public Health here in Houston, Texas, and also with the Karnataka Institute of Medical Sciences in Hubli, India.
Yeah, I did.
Good morning, everyone. Thank you very much for inviting me to speak on this topic. So this is about traumatic brain injury triage in India. Traumatic brain injury is a big problem. It's either in the United States or in India. It's a big problem. But the situations in both the countries are totally different. We have a good infrastructure here in the United States. We have an excellent emergency medical care system compared to India right here. But in India, it's poor. So before we can go into details of my study, I would like to do a comparison of how we can compare USA and India. So number of hospital beds per 10,000 population. In USA, it's 30, and in India, it's about 9. And that's a ratio of about 3:1. And the doctor-patient ratio in USA is 1:390. And in India, it's 1:1700. That's about 1:4 ratio. And the people who take care of patients with traumatic brain injury are neurosurgeons, and the neurosurgical workforce is 1:62,000 in the United States, and it's 1:1 million in India. And one of the most important devices that's needed to diagnose traumatic brain injury or even advanced management of traumatic brain injury is CT scanner. And for a million population, there are about 40 CT scanners in the United States. And there's about 2 or 2.5. That's because one might be broken or one might be not available. So that's that. And emergency medical service. It's pretty well established in the United States. We have helicopter service, Life Flight, which is Memorial Hermann. That's doing a great job. But we have no such thing back in India. And Global Competitive Index has this thing to assess the quality of roads, and on a scale of 0 to 7, 0 being no roads existing to 7 the best roads possible. United States, it's 6.5. That's excluding Houston. And India, it's 3.2. So let me go to the background. That is southern India. Let me use the pointer. Okay, that is southern India. And this right here is Hubli. This is where I went to medical school. And this is a small city, but around the city is a lot of villages which use the services offered by the hospital in this one place. And it's a government-run hospital. So these are the conditions of the roads that leads from the villages across the city into our hospital. So imagine a patient with a head injury. He needs to be brought into the city with these roads. So while transporting a patient with head injury, the people transporting the patients with head injury are at risk for head injury. That's because it's not only because of the bad roads, but we don't have safety equipments like airbags compulsorily to be in all the vehicles. That's one more thing. So this is what we did. I came up with this idea that there's something called revised trauma score, widely used across the world for emergency triage. It basically uses 3 simple clinical tools. One is Glasgow Coma Score. The second is systolic blood pressure, and the third is respiratory rate. These are the vital stats that's given for all the patients who enter the emergency room. So combining these 3 things, we can have a score. That score ranges from 0 to 12. 12 is delayed, that is, there is no emergency treatment required urgently. 11 is urgent, and anything between 10 and 3 needs immediate attention. This is one tool that we as clinicians have. The other tool we had was something called Marshall CT classification. So this goes 1, no pathology seen, to 4, worse pathology seen on CT scan. So the big idea was to see if the clinical tool, that revised trauma score, can be correlated with the Marshall CT classification. If that's possible, then we can conclude that we can decide who needs the CT first. Because I remember in our institution, as I said before, we had 2 CT scanners, just 2. And one of them was broken, so we had to triage the patients. And this is what we did. I, along with my other colleague, he was a medical student, he's my junior medical student, Vijay. What we did was every day in June, from 24 hours basically, we took turns sitting in the ER and assigning prospectively the revised trauma score for the 54 patients that came to the ER with head injury. And then, this is my neurosurgeon, Krantikern, he assigned the Marshall CT score. So what we did at the end of a month is we tried to put the results together. And this is some stats right there. About 80% of them are men and 20% female. The average age was 36 years, ranging from 10 to 52 years. And the causes of head injury, most of them were road traffic accidents. That is why, revised trauma score, which is essentially mostly meant for road traffic accidents, was used because most of our patients are road traffic accidents. 24% are fall from other causes. I'm stepping onto the stage right here. I might slip and fall. I may have a head injury. So that kind of fall. And you might be wondering what those 6% is. Let me give you an example. The 6% is funny because that's about 2 cases, because I have 54. So those 2 cases were actually bull-gore injury. Can you imagine how bull-gore injury is possible, right? Because the cultural competency of the public health school of public health here will teach us that bulls, cows, elephants, horses are common across India. So they take the roads, they sit on the roads, and they cause the injuries. That's that. And the results. The RTS severity was positively correlated with CT severity. If RTS score was severe, that is 10 to 3, then it was correlated with a worse CT outcome. And it was also positively correlated with death in the ER. And patients requiring immediate triage were more likely to have used alcohol. Again, it's a whole thing all over again. Road traffic accidents, alcohol.
I'm sorry, we'll have to wrap up pretty soon.
Okay, that's it. So there you go. Conclusion, RTS is a very powerful clinical tool in resource-limited settings like India. And emergency medical services in developing countries like India, Pakistan, Bangladesh, Sri Lanka should use RTS to enhance emergency head injury care. That's it. Thank you.
We'll take one quick question if there is any.
Are there any plans for follow-up studies? For example, I know that one of the biggest issues with pediatric emergency medicine, this is what I love, but one of the biggest issues is to know whether to CT or not.
Okay.
And so do you have any follow-up plans to be able to kind of prospectively assign an RTS category and then not CT and just observe clinically so you can make recommendations on who do you need to see to and who not to? Since many times in a country there's one CT scanner in the capital, so if you can prevent that use of resources, it's a good one.
Well, that's actually a good question. There was, in 2009, there was a study by UCSD, a group of people from UCSD. They designed this clinical algorithm to decide who needs to get CT. Among kids, they divided the patient between 0 to 2 and 2 to 18 and decided who needs to get CT and who does not. So if we can actually implement that in pediatric population here, probably that would be an additional tool to triage the patients. We can triage using that and then triage using RTS. Then we can have a better tool to assess who needs the CT. Yeah.
Thank you very much for your presentation.
Next up in this room is going to be Maria and Elena Batazzi talking about combating neglected tropical diseases. Okay?
Do you want to
Thank you.
switch it back to? Oh, there's a break now?
Unfortunately, I don't think this room is going to have time for a break. We're going to move on to the next section. So there'll be oral abstracts next door.